So hello and welcome to today's webinar. I'm thrilled to welcome you to, this is the third installment of our Best Practices webinar series. This is Best Practices for ROI and Clinical Operations for Remote Patient Monitoring. I'm Drew Schiller. I'm the CEO here at Validic, and I will be serving as the moderator and also providing some color commentary for today's session. Just a couple of housekeeping items. Today, we are going to focus the conversation on remote patient monitoring ROI and how to strategically define and evaluate ROI in a remote monitoring program, as well as clinical operations. So how to operationalize remote patient monitoring programs to achieve sustainable results at scale. Before we dive into the discussion today, a couple of items. One is this webinar is being recorded and will be available on demand within about 48 hours after the event. So keep an eye out for an email from us with the recording. We have a lot of time set aside to answer questions from the audience. So please submit those questions via the Q&A box below. It's a lot easier for us to track the questions if you use the Q&A box as opposed to the chat functionality. So we'll get as many of those questions answered as we can. If we don't get to those questions, we'll try our best to follow up afterward if there's anything relevant that we can provide relative to those questions. But this is an excellent opportunity for you to get Angie, Sara, and Nelson's thoughts on what matters to you most. Also as part of this, I'd like to mention that we have an upcoming Best Practices webinar series. There'll be the final installment following today's presentation. That will be on January 12th. And that will also feature me. I will be joined by Cleveland Clinic, CVS Health, and Prisma Health to discuss upcoming trends in digital health and remote monitoring and consumer expectations for on-demand services and consumer-centric experiences. So our team is going to drop the link to register for the event if you haven't yet had the opportunity to do that. And we are super excited and really look forward to you hopefully joining us for that webinar as well. Before we get started today, I'd really just like to level set briefly on kind of what we're seeing in the market. You know, since COVID hit, we are really living in a virtual first world. And I mean, that extends even into the workplace. You know, Validic as a company is now a remote first company, and we've hired at least half as many people who are remote outside of the headquarters of our Raleigh-Durham area as what we had previously been doing before the pandemic hit. And you know, we are now very virtual in terms of how we communicate with everybody, both at work as well as in our daily lives. And living in this sort of hybrid virtual / in-person world, people are starting to expect the same type of experience from healthcare. And I think that we can all agree this is not going away, right? When the pandemic hit, we all went very virtual very fast, and everything was a video or telephone visit. Obviously, that has started to come back, and we've had a lot of in-person, but I think we're going to see a lot more hybrid going forward. And what I really like to spend today on discussing is how we think that future of healthcare is going to look, specifically through the lens of virtual care and remotely caring for people in their homes in this kind of virtual world. So today we have three incredible speakers joining us. I'm going to let each speaker introduce themselves, and then also, while they're introducing themselves, name something exciting that about remote monitoring and virtual care, or name something that excites them about remote monitoring and virtual care as it relates to their field and organization. So, Angie, why don't we start with you? If you could just introduce yourself and your background, as well as, you know, what excites you right now about this space.
Thanks, Drew. I really appreciate the opportunity to be here. I am the Chief Strategy Officer for Ironbow Technologies in the healthcare division. If you're not familiar with us, we actually are partnered tightly with the Office of Connected Care at the VA and provide all of their virtual care solutions. So that's a program that's been going on for now about 11 years. So a lot of success there. Prior to joining Ironbow, I was with Kaiser Permanente and ran their enterprise-wide telehealth solutions. And I've been in healthcare IT my entire career. So I've had the opportunity to see a lot of change and evolution, not just in healthcare, but in the technology. And so when you ask about what excites me, I think what excites me most is that we're actually starting to shift towards value-based care. And as we shift towards value-based care, we're having to incorporate tools and technologies that can support that model. And I think remote patient monitoring is one of those that is critical to that change, because we're no longer looking at how do we treat people during episodic care when they have issues, but how do we have a continuous engagement with them to promote health? And that's really what excites me right now about where we're at. And I think it was, obviously stimulated quite a bit by COVID.
Yeah.
Thanks.
Absolutely. Yeah. Thanks so much, Angie. Welcome. And Sara, how about you?
Thanks, Drew. Hi, everyone. I'm Sara Vaezy. I'm the SVP and Chief of Digital and Growth Strategy at Providence. We're a large integrated delivery network in the Western United States. We span from Alaska all the way through Washington, Montana, Oregon, California, Texas, and New Mexico. So we have a really broad scope of in terms of our geographic coverage, as well as our sort of vertical integration. We have a health plan. We do a lot in acute, ambulatory, post-acute. We actually have a high school and a university as well. So Providence, it really extends its reach into health in addition to healthcare, and even the sort of upstream determinants of health. And I sit within the Digital Innovation Group, which is a group that really is focused on sort of the digital transformation of the consumer or patient-facing front end of the organization. And we kind of have two outcomes of our work. We either partner with organizations, other companies, in order to sort of solve the big problems that Providence is dealing with within that domain around our patient consumer front end, or we incubate technology as well. And we've spun out a couple of companies in that space. And so, the thing that excites me, Angie actually kind of stole my line, so which I love. So I'll add something kind of different and maybe nerd out a little bit, just that I think it's very cool that as we've entered into this, all of the negative things that have come with the COVID world, one of the things that's really cool is it's increased the degrees of freedom around how we can think about care delivery and the creativity that we can pull in to care for folks in not just, virtual or physical, but when you start talking about digital, and we'll get more into this, of course, it really just opens up the aperture of like all the different things you can do. It can be real time, it could be asynchronous, it could be chat based, it could be, bot based, it could be human powered. There's all sorts of things. And then how you solve that sort of multifactorial problem, that's where I nerd out on it. I think it's very exciting. And it's also going to really make a difference. We can do super interesting and creative things within the context of new business models and enable new business models with these degrees of freedom. So that's, I'll stop there for now.
Yeah, that's super exciting. And I definitely want to pull the thread a little bit more on new business models. And I know we'll get there. So that's super exciting. And Nelson, please introduce yourself and what's exciting you right now.
Yeah, thanks, Drew. And so honored to be part of this panel with you and the Validic team and Sara and Angie as well. So my name is Nelson Lee. I'm a physician by training. I spent my career taking care of patients as a pediatric cardiologist, but I am too a data nerd and data geek. So transitioned to healthcare IT 12 years ago, and that's where I've been spending my career. I work for Humana, and for most of you, you probably know Humana as a health plan, but the way we would refer to ourselves, we're a healthcare company. We're branching out to care delivery and also having a payer agnostic model to take care of our members, as well as branching to pharmacy as well. Which is a really big, robust part of our business. So excited to be there. I work in digital health analytics. I lead digital product strategy as one of the AVPs there. And so, gosh, there's so much to be excited about remote monitoring virtual care. And I guess I would index on two things. For our Humana, delivering care in the home is really core to our strategy. And we've done this by expanding our network of home health providers with our acquisition of Kindred Home and One Home this past year. We've also really been working on our telephonic care management to deliver a world-class service to our members. And I really firmly believe that remote monitoring virtual care are critical and complementary services to delivering care in the home. So that's really exciting to me. And then the last thing I'll say, and Angie and Sara really touched on this already, is actually seeing the sustained utilization of virtual care in this pandemic, right? I think pre-pandemic, I think it was less than 1% of our visits were being done via virtual care. And then at the height of COVID, we were actually in the 35% of our visits were all done via telehealth and virtual care. And now we're probably selling back down to like maybe the mid-teens, and that's what the industry is seeing as well. But like Sara said, what that really opens up is the opportunity to think about new care models. And you touch on this, Drew, around this hybrid approach. And I think that's where we're headed as well. So those are the two things that really excite me.
Yeah, that's awesome. Thank you so much. And I'm honored to be helping to moderate this group. And it's one of the true privileges of being with a company like Validic, where we have the opportunity to engage with health plans, health systems, large strategic technology partners in the industry. And so I'm super appreciative for this group. Thank you so much. And I think that with the background of the payer, the provider, and the large IT organization, I think we're going to have a lot of really interesting, robust dialogue. And to start with, I'd love to have, as a first question, I'm going to kick it over to you, Sara, which is, what criteria do you look at when thinking through the business case of virtual care and remote monitoring solutions?
Well, so I'll give a little bit of context, and just to say that I think it's kind of ever evolving. And part of that is because Providence is a largely fee-for-service organization. We do have some pockets where we hold significant risk, for instance, within our health plan and within our caregiver ACO. We call our employees caregivers, and some other areas where we are moving more and more into value-based models. But largely, we are a fee-for-service model. So, the answer will sort of be, it depends on what patient population, what region, what payer, type that the patients have, what conditions they have. But, sort of most, I would say most fundamentally, from a longer term sort of strategic vision standpoint, our organization is moving very intentionally toward building out the care continuum of care, both physical and digital, that sits outside of our traditional capital intense hospital acute settings. And so so with that in mind, how we can, some of the things that some of the criteria that we use are, the ability to care for patients outside of their home in a safe, high value, clinically appropriate, et cetera, kind of way. Like, those are kind of the general high level ones. And then we start to look at, reducing total cost of care, or reducing total cost of an episode, depending on whether we're looking at chronic conditions or things like post-discharge for a specific episode of care. We look at all of those things, and those are some of the kind of criteria that we're thinking about. But more generally, I would say, does it support this movement outside of the acute setting? And then the other thing, which is a little bit nuanced, is how can we think about this in a way that doesn't require us as a health system to time the transition economics of moving from fee-for-service to value? That is extremely difficult to do, especially like for anybody, but it's especially difficult to do for a health system that is as large and as varied and regional as Providence. And so and we'll talk a little bit more about ROI later today, but like that those are some of the criteria. And so it's not just about we talk like RPM, we know it reduces total cost of care if done right for the right conditions, but that's not the only kind of thing that we're going for. It really has to help us in a business model transformation, kind of first and foremost. And it's much more about the last thing I'll say just on this note, and then I'll stop talking, is it's much more than just about feature and functionality. I think there's lots of different RPM platforms, and frankly, like virtual capabilities have just exploded over the last couple of years. But the features and functionality are not what make these different technologies or different enablers special. It's the ability to think beyond just infrastructure and to solve for some of those things that I mentioned, like how do you solve this multifactorial problem across different modalities, across different venues, and things like that. So I know that's kind of a high level answer, but it's a pretty, it's a pretty complex set of things that we're trying to manage as we, given our environment, technology wise, as well as business wise.
Yeah, totally. And Nelson, what are your thoughts on this?
Yeah, the only thing I'll add, and Sarah articulated well, I mean, we have, as any other organization, we have the big blocks of clinical value, operational value, business value, and then also value to the member directly. I will say that the one thing that we are very mindful of is how do you take this data and contextualize the data, right? And so it's more on, that's part of our approach as well. Is like, we can do remote monitoring and get all this data in, but what do you do with it? And is really important. And how does that allow you to have a better understanding of who your patient, your member is? So that's one of the criteria as well that we evaluate when we're trying to figure out what programs do we want to stand up and why do we want to stand up? And then what do we do with that data is really important. And so that's part of our criteria when we're trying to dimensionalize the program.
Yeah, that makes a lot of sense. And Angie, I know you and I got connected when you were leading virtual care at Kaiser Permanente. And this is something that I know Kaiser put a lot of thought into around the business case. So I'm just curious from that perspective, or currently where you're at with Ironbow and your clients, how do you think about the business case around these virtual care strategies?
Yeah, I think Sara and Nelson covered it fairly well. I think the other aspect of it is when you go to deploy these types of solutions, there's a couple things when it comes to the operational workflow and how do you operationalize for scale. One is that you want to make sure that you can embed this into existing workflows as it makes sense. I think you don't want to just take a manual process and make it digital. So there are some operational changes, and this is a real opportunity to drive some of those changes. Where, like for example, we struggled with, some of our groups doing care management for diabetic patients and other groups doing care management for, people with hypertension. The thing is, those are often comorbidities. And so you can't really treat them separately. And so going back to what Nelson said too, is as you collect this data, how are you leveraging it to really personalize that care? What's normal for me is not the standard normal. And so you need to have that data and trending over time from people when they're in their natural settings, not when they come in, for a checkup. And so there's so much power there when you're looking at, what is the operational impact of it? And then finding the right areas where you have basically clinical leaders that are really bought into how this can help them as well as help their patients. Because if you don't have that clinician engagement up front and ongoing and just them being evangelists out there, you'll struggle with adoption.
Yeah, I totally agree with that. I think that's a great point. And so, building off that, Nelson, I'm going to kick it over to you and ask you about the use cases and the populations that make sense for investment in these virtual care and remote monitoring strategies. And maybe just even prime that a little bit more specifically. There are certainly more acute use cases that have a ton of immediate application and relevance to reducing costs and around readmissions, et cetera. And then we also have obviously the long-term chronic diseases that, if not managed properly up front, get worse and add to comorbidities and then end up being much more costly for the healthcare system. So I'm just curious, how do you think about these use cases and how would you maybe see those evolving?
Yeah, I wish there was an easy playbook that we can just sort of pass around and say, hey, this is the population, this is what you do. But of course, we know that it's not that easy. I mean, I guess if we step back and think about the value of remote monitoring and virtual care, it's around truly gaining visibility into your patient or member's journey when they're not in front of you, right? And so we sort of take that same approach at Humana. It's around, how do I understand what my members' health is doing, their disease progression, and then how do I mitigate the risk, right? Wherever that risk is. So I think our perspective is really around behavior change, right? So if you can identify what behavior you're trying to change, then ask yourself, what are the leading indicators that this behavior is about to happen? Can I monitor these leading indicators? And then how do I intervene? So if you take this rubric, you can apply it to COPD, CHF, diabetes, post-surgery, whatever it is, and say, whatever I'm trying to change, how can I move upstream of that behavior and start tracking that? And so that's how we sort of done this. And you can, like I said, you can apply this to any disease state, and that's how we've approached this. To your second part of your question, how do we see this evolving over time? I would say it's more around the precision, right? So as technology gets more precise in what we can monitor, we too can get more precise in what target populations we want to track, what exactly do we want to measure. So if you think about the old CHF programs of the past, what do? We send everyone to scale, like thousands of patients to scale, and say, hey, go weigh yourself, and we're going to find out who's having CHF decompensation. But as technology has gotten more sophisticated with Fitbits and O2 sats and other things that can say, hey, these are better markers of the leading indicator, we now can start targeting better populations and then therefore change their behavior. So that's how I see this evolving. It's around precision and accuracy.
If I could just add something to what Nelson said, because it just really resonates, which is precision and accuracy also are related to engagement and personalization, right? And the more that you can do that, the more relevant it is, the more you can prompt next best action in the different settings in which you're interacting with your patients. That's extremely powerful. And I think Angie actually mentioned it, or maybe Nelson did, or maybe both did. But it really is about, let's say on average, interact with our between patients and providers like 2.5 times a year or whatever is like the kind of common standard. Taking that up to like 12 or 24, and doing so in a way that is relevant. You're not just hounding people, and it's in the context of that like particular next best action that they can take. It's really powerful. And that increasing level of precision, I think that Nelson just referenced, is what's going to make that really worthwhile and have greater utility for the patient, because you're not just, generically reaching out to them. There's actually context to it.
Mm-hmm.
Yeah, absolutely. I think that's a really great point, and something we think a lot about at Validic around how, it's one thing to be able to capture readings that people are creating in their daily lives, but how do we actually understand the context around those readings, and how do we to make those readings more rich, and to know maybe even more proactively if it's something that needs to be escalated to a clinical care team member to take action on, versus something that was an errant reading, or not something that necessarily needs to have immediate action taken today, to just help make the healthcare system much more effective and efficient. So that sort of tailoring on that side as well. Angie, anything to add on this thought?
Yeah, no, I think you kind of hit on it. It's a bit of, the so what factor. I got your data, so what? But you take that information and you combine it, as Sara and Nelson mentioned, with other information you may have, and eventually with genetic information. And we're really starting to personalize care. So I think sometimes people get a little bit short-sighted when they implement the programs and think about, what is it giving me today? What's it going to give you over time? What's it going to give you when you get more of this information, you're able to combine it together and really start applying, machine learning and some AI to these large amounts of data? I think we're all going to be benefiting, no matter where we're at in our health journey, from these types of tools.
The one thing I'll add is that I think the precision is also with the study design, right? So I think we've all seen with remote monitoring programs, attrition over time, because someone's saying, hey, I'm stepping on this scale every single day, but I'm really low risk, so why am I doing this? And on the other end of the spectrum, I'm a really, really sick patient. You're having me stay on the scale, but you're going to call me anyway because of all these other reasons. So why am I staying on the scale? And so again, it's like really honing in, and everyone's kind of said this, the target population, the right intervention, and the right sort of remote monitoring program. That's really important to keep the utilization and the adoption as well. So.
Yeah, totally. No, I think that makes a lot of sense. And Angie, I love sort of where you're going with your last statement. It made me think, I think we can all agree in some future time, call it 5 years, 10 years, whatever, we will all be in this place where we have the data that we need to put people in the right programs for the right care, where it's streamlined, where it's effective, it's engaging, it lowers the total cost of care, improves outcomes. And so I think that's why we're all doing this, right? Is because we strongly believe and know that that is where all of this is headed. So to get a little bit more tactical on sort of how we start to get there, one foot in front of the other. So I'd love to turn to you and then Nelson and just ask, what are maybe some of the realistic goals that we can have for remote monitoring programs and sort of early ROI targets for these, and how might they differ between health systems and plans? And I'll maybe even specifically say, Sara, thinking through, you mentioned that there's clinical utility in this, but there also has to be the financial utility. And I feel like everyone really understands well the clinical applications today, but it's that financial piece that's a little bit more challenging. And why don't those align as well as they should?
Well, I think Angie kind of said something that was super interesting, which is we can be short-sighted and look only at today versus over time. And it's absolutely true. The problem is like cash flow is an issue, right? Especially for providers who don't own premium dollar. And so that's what we have to manage. And I think, one thing we haven't talked about, which is not often part of the business case or the ROI case for remote monitoring, is the potential. Now, there's workflow implications and a lot of other things that actually Angie and Nelson have already talked about as well in order to make this happen. But the potential for digital and for remote monitoring to increase capacity and therefore be a vehicle for growth. And that allows you to function in any economic environment. So I actually think that is a near-term ROI kind of measure that you can use to buy yourself time, right? And to get to that point where you have, over time, you can look at, long-term value accrual, across a population. Now, the challenge there is you actually have to adjust the operations so that you can make room for that growth to be realized. But that would be that's the number one short term for like a fee-for-service based environment. That is the number one short-term ROI driver. And then we're looking at, in addition to that, though I will say these are not the initial use cases that we're using. We're looking at things like reduced total cost of an episode if you're able to discharge patients out of the hospital from like a surgical experience and then monitor them in the setting of their home and things like that. So that's another near-term ROI kind of driver that I think is really powerful. And just one data point that I'll give on the capacity and growth front. One of the things that we did, and we saw this play out in real time with COVID, was trying to keep folks out of the hospital. That was the first actually remote monitoring program that we stood up at scale across the system. And we saw tens of thousands of patients go through that otherwise potentially would have been in our hospitals. And we were at capacity, right? So we would have had to either go on divert or do something else. And so it did actually enable us to care for tens of thousands of patients without, and then, what does that mean in terms of growth? Well, now we have my chart with them. We have that lasting relationship. We can reach out to them. We can build that ongoing kind of partnership. So anyway, those are a couple of, I think, near-term kind of opportunities that can bridge to the longer term ROI drivers, which are reducing total cost of care for chronic conditions and things like that.
Yeah, I totally agree. And I'm glad you answered this question first, Sara, because it's not an easy question to answer. So thank you for doing that. To answer your question, Drew, I don't think that the goals and targets between health plans and health systems are that different, right? Ultimately, we are trying to keep our members and our patients healthy. I mean, that's the goal. I really want to, again, double down on what Sara said around efficiency, right? So it's right now for many health systems and health plans, our way of tracking our members is telephonic. We pick up the phone, we call in, we check in, and that's just not sustainable over time. So if we were able to stratify our members to say, hey, these members definitely need a live touch point, maybe an office visit, And there's folks that we can maybe sort of slow roll in our interaction, but there's probably a middle tier where we want to keep closer tabs. So how can we use remote monitoring and virtual care to just create more capacity and also efficiency in reaching our members? But there's also this other concept of engagement, and that's really hard to quantify. But we firmly believe that someone who's engaged in remote monitoring, that's an opportunity to get them engaged into other services as well. And we get them engaged into their own health. And that's really hard to measure, but I can say for certain that some of our members, when they're in a remote monitoring program, they're going to take their meds, they're going to exercise, they're going to eat well because they know they're being monitored over time. And that's a behavior change that we hopefully will sustain. So I think that's really important. But we've also seen that once a member has sort of engaged in a remote monitoring program, they kind of realize, wow, there's probably a lot of other things that I can get engaged into, such as a Silver Sneakers program or maybe a nutritional program. So there's all of these good unintended consequences of an RM program that's really hard to quantify.
That's a great point. Thank you. Yeah, I completely agree with that. And just to highlight a little bit of that is that what we've seen with our programs is that, in fact, one in particular that I worked with Angie to put in place at Kaiser Permanente, which I'm going to ask you about now, Angie, is that for the clinical team members, 90% of clinicians feel like the program saves them time, as well as 90% of physicians feel like they're delivering better care. And the efficiency on the clinical side is also was very significant too, where the average call time between clinicians and patients actually dropped by about over 60%. It's 15 minutes down to 5.5 minutes for an average call. So there's a ton of clinical efficiency to be realized here. And Angie, just to turn the question over to you, on the clinical side, there's been about 6,000 physicians, a little over that have now enrolled patients in the programs that you helped really design and put in place while you're there. So, getting tactical from those early days and building an operational giant like you're able to put in place, what are the sort of realistic operational goals for new introduced remote monitoring programs over the first year or two, and how should folks be thinking about where they should be targeting operationally?
Yeah, I think one thing to keep in mind is you can have a generic playbook, and we did put one together that could be leveraged across the different regions and different departments. But realistically, it's not a one size fits all, because departments have their kind of own culture and their own thing going on, and clinicians have the way that they engage with their patients. But you have to you kind of have to meet them where they're at. So those operational efficiency gains that you're talking about that Kaiser Permanente achieved was really based on their existing care management program, where people marked down their blood glucose level and their weight and things like that on a piece of paper. And then they called in and probably fibbed a little bit about the actual data. And, the nurse keyed it in. Well, that takes a long time. And so what they were able to achieve is looking at a broader population and having the clinical alerts provided by the system. Those alerts had to be clinically significant and actionable. And so then you have this whole panel of patients that you're looking at, and you can see green, 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 green. These are all fine. These are the ones that need an intervention. And even then, when you call them, you're not writing down or collecting their data. The data is already there, and you're just reviewing it with them and talking about what are the next steps and how can you improve that moving forward. So I think again, you have to probably start out, and we started out, relatively small with a tight group of clinicians, again, that were super bought into this and really wanted it to work. So they dealt with the little bumps and bruises, and this isn't exactly the way I want it. And then as we progressed, we were able to add capabilities and then also just grow in utilization across the regions. So it takes time. You have to be patient. You have to be diligent. And then I think you also have to really lay out your metrics and manage back to those metrics. And it doesn't mean that you set targets and say, I'm going to hit, a panel of 400 patients per nurse within the first 2 months. That's probably unrealistic. If that's your ultimate target, you measure along the way to make sure you're directionally going in the right way. And if you're not, you have to be willing to step back and say, you know what, we need to adjust. It's not a failure to identify that your metrics aren't going exactly the direction you want them to go. That's a success. That means you're actually looking at it objectively and you're making adjustments to the program. So I think that's also a cultural thing that people have to accept as well. it's not going to be perfect on day one. It's not going to be perfect on day 365. I mean, this is a journey that is going to continue indefinitely, from what I can tell.
Yeah, I think that's a super important point. And, I think that that sort of agile mentality has not been something that has been front and center with how many health systems and plans have adopted technologies. And I think one of the reasons why we see so many sort of outsourced partnerships where the entire clinical stack is outsourced to another provider. But, Nelson, maybe to turn this back on you a little bit, with the acquisition of Kindred, right, we're seeing more insourcing. We're seeing that organizations want to actually have more of these capabilities in-house. So I'm just curious how you might think about the operational goals of these programs. And a health plan is a little different in that you have a lot more of a focus on home health as well as care management capabilities as opposed to clinical team members directly, physicians directly. How would you think about those operational metrics in the first couple of years?
Yeah, I would say it's around, for us, it's around integration, right? So if you think about the different capabilities, home health, care management, remote monitoring, you can imagine if those were all siloed off, that it would just be one, inefficient, but more importantly, we wouldn't be serving our members well. And so how can we, when we have our home health nurse in there in the home, help set up the RM program, right? And so get the patient all set up, make sure the devices are working. So there's just those little simple things that increase adoption, utilization, and decrease attrition over time, right? So that's one thing. But then also the reverse. How can we think about once we have the data coming back from the RM program, we need someone to come into the home. Well, now we integrate with home health, who's already in the home, right? So taking all these different capabilities, integrating them into sort of one holistic program is how you're successful. And so I think that the acquisition of Kindred was a big play for us. And we could easily just partition it off and say we have home health, but I think that would be a miss on our part, right? And so we were very, very intentional of integrating home health with RM, with care management to create more of a holistic program. And so you can sort of think about integration across the entire ecosystem for Humana, but talking about the home, that's how we're thinking about what we're doing in year one.
Yeah, I think that's an exciting story. And Sara, I'm just curious, your perspective and like the many programs that you've implemented at Providence, certainly not just remote monitoring, right, but across the virtual care spectrum. How do you think about taking those initiatives from idea and incubation to actually starting to roll them out and setting up achievable operational metrics, understanding that, the healthcare system is built around a bunch of folks who are used to getting straight A's in college, and now you're trying to say embrace the failure?
Well, I think the first step is to find, actually, let me back up. There's this sort of myth, and I think we've busted it, and I've been talking about busting this myth for like the last couple of years, since actually March of 2020, which is that you either are able to kind of move fast in technology and healthcare by being on you're either able to move fast and be separate, or you move slow and you're deeply integrated into the health system. That's a false dichotomy. We actually worked super, super close hand in hand with clinicians, like in the early days, for instance, in March, when we were developing our COVID screening and triage chatbot, right? That's just one example. But it really required that deep integration with the clinical and operational side of the house. And that's really a lesson that we are now taking to anything that we do, which is, number one, find a clinical and operational champion who's willing to tolerate that sort of environment where you're like, it actually might be more difficult for a while. You may fail, and but here's why this is important, and what we're kind of the vision of what we're trying to work toward. We have several disciplines, like for instance, we take the Amazon working backward press release discipline, and we write up like, what's the vision for this thing? How are we going to work toward it, et cetera. And so, find someone to work with, paint the vision, have that tolerance for some pain in the interim, and then really co-design in with them. And it doesn't always work, but at least it works pretty well in terms of let's identify something pretty well-defined, specific that we can work on together. So like we kind of call it like the rifle shot, and then you can expand from there. The biggest challenge that we candidly have within our system is that scaling part. So we get the evaluate, we can get through ideation, we can get through evaluation, we can get through testing, but then we really struggle still. And that's because it really has to get worked into, again, I think what Angie had mentioned at the beginning, the deep operational changes, the people, process, operations changes that are required. And those are the things that are going to drive ongoing, for instance, adoption, sign up, and then engagement is a whole other set of challenges as well. So, so it's that latter half that is, I think we still have kind of both us as Providence, but also kind of collectively as an industry, a lot of work to do. And some of it, you know, we saw it as an industry where we had spikes in virtual health utilization, digital, you know, video visits, et cetera, at the beginning of COVID, and then quite a bit of tapering off again, because it was like this sort of substitutive mentality, or like a, you know, kind of one-off mentality, as opposed to like deep integration and transformation.
Yeah, I think that makes a ton of sense. And, you know, I think you lead to a really good point around some of the challenges that folks see, especially around, you know, maybe things they hadn't considered. And so I'm gonna ask a question around that. But first, I just want to remind everybody that if you have questions as we're coming up in the last 15 minutes, feel free to open up the Q&A capability in the Zoom and pepper us with some questions. And Angie, maybe I'll turn over to you first to just answer what is the challenge of getting these programs up and running and off the ground that folks might not even initially consider? Like, what was something that really surprised you was a challenge when first starting to implement a program like this?
You know, I think these are things that we kind of knew would be challenges, but we didn't realize how big of challenges they would be. So you have the cultural aspect that we've already talked about. So it's not just a shift in operational processes. It is a cultural shift to want to deliver care through digital means. So fortunately, Kaiser Permanente and the VA are both just very progressive in that regard. So those things weren't as difficult as some of just the tactical things. And so supporting patients with devices and technology that's new to them. I mean, I remember when we started this, I handed my mom a Fitbit and said, here you go set it up. And she couldn't do it. And she got frustrated really quickly and threw it aside, because, you know, they don't even come with directions anymore. I mean, they come with, you better understand how to connect this. So, so we had to make sure we had strong technical support that could work with all levels of capabilities, you know, and because you're dealing with patients with their own devices out there, we had to really get a good knowledge set of how to deal with all these different versions of the devices and all of that. So that was a little bit harder than we expected. The calls were longer than we expected. The other part that I think is challenging and continues to be is device distribution, and how do you get it paid for, and, you know, how do you manage it, and any warranty issues. Fortunately, they're not as expensive as they used to be, so now you can pretty much ship and forget. But, you know, for a while there, it was like, how do you get it back? You know, and that'll still be the case when you get to some of those more advanced use cases where it's more of a hospital at home scenario. So I would say tactical things were really hard. Yeah,
absolutely. Yeah, Nelson, any thoughts on that?
Yeah, I'll add two things, and you know, to play off of what Angie said, I think there's probably front end things that we learned, and also back end things, right? So on the front end, and I think we knew this, but we didn't really understand. We saw the value of clinical buy-in, right? And so it's easy for us to send someone a device, but, you know, getting a device from Humana versus getting a device that, you know, nurse Sally said, hey, this is really important, Nelson, you really want to do this program. There's just a different level of trust and confidence when you get the clinicians to recommend a solution, recommend a remote monitoring program. Getting the physicians in the primary care clinics to also recommend it and buy into it and evangelize the importance of this program is so important to recruiting. And so that, I think we knew that, but we really saw the value of it when we were actually setting up programs. And then on the back end, for us, it's all around data integration. And so we built some really nice dashboards that had, you know, like Angie said, the green, yellow, red, and who to contact. But when you actually sat down to talk to the nurses, they said, well, I know why that's red, because this patient's doing X, Y, or Z. So how do you contextualize that data marry it up to the patient profile and the patient record. So that way, when you look at it, it made sense. And then you can there stratify it. So it's not looking at the data in a silo, but as I mentioned before, contextualizing that data in regards to that patient. So then you can actually personalize the intervention was really important and something that I think, anyone who's seeing a program should be mindful of.
Yeah, that's great. Yeah, thanks for that. Sara, any other than the scaling, any other sort of out of the blue challenges that you've seen?
No, the scaling one is the biggest one. I'll give one other example, which is just that, like, we often health systems, we and I think Angie referenced this, like, we manage by dashboard. But if you're getting into like thousands of patients, you can't manage by dashboard. You have to manage by exception. And that has to have meaningful alerts and a whole host of other things to make that exception framework work. And I think that scaling challenge exists at every level. So it is a really tough problem to solve, that the thing is that we and I think we talked about this already, right? Like, you got to start these programs small, but you got to envision what that scale is going to look like so you can kind of plan for it. And if you build something that, for instance, only allows you to manage via dashboard, you're going to be in trouble.
Yeah, absolutely. I think that's such a great point. I will add one more challenge that I at least see from the outside, which is getting broad organizational buy-in from the top is a big challenge that, frankly, is still something that surprises me how often this becomes a bit of a challenge where, you have groups and or, even a large number of executives who are bought into the strategy, but it really oftentimes only takes one or two folks, whether it's, it could be in a clinical team, it could be in a product team, it could be in a procurement or legal team, but their data security team, right? If there's somebody who's not brought in or bought in on the top level vision to make it happen, it can really slow down the progress and kind of deflate the balloon of a lot of enthusiasm, where otherwise there would be a lot of enthusiasm. And so, I think that one thing that I've found for organizations that have done really well with these initiatives is that there is a top level alignment and everybody understands why this is strategically important, as opposed to, just sort of allowing the, sort of crackpots in the corner, like peppering in with sort of well, this is why it's not going to work or whatever. And then sort of taking it off course. But Angie, I'd love to turn it to you really quick to talk specifically about that scaling challenge that Sara mentioned, because the program, going back again to the program that we have in place at Kaiser Permanente, that now has 250,000 people who've been enrolled in that program. There's, this is diabetes, hypertension, heart failure. It's deployed nationally across 7 regions of Kaiser. It's been very successful. And, I think to Sara's point, when you were conceptualizing that program, you started with the end in mind, right? And I think that was because of a lot of fast iterations and realizing quickly what wasn't going to work. But I was just wondering if you could quickly talk on, what are some of the early decisions you made that enabled Kaiser to put in place a program that really is scaling operationally to the size that it is today?
Yeah, I think we did a few things. First, I think Sara mentioned this on how they work as well, is that we brought in clinicians early and we had them on the journey from the very beginning, and their input was, at the top of the list, absolutely, because they're the ones that have to leverage the technology and engage the patients. And to Nelson's point, it means more when they do. So that was a key aspect. I think when you take the approach of, I found a solution and now I'm going to somewhat impose it on you, that doesn't go well. So you really want to bring people into the process early. And then I think centralizing those things that are challenging for them so that they don't have to figure everything out locally. So support, distribution of devices, those things that I said that can be really difficult, take those problems off of the clinicians, let the clinicians focus on delivering care. And so I think that helped as well. And then I think going back and like aligning the design, to the mission of KP. So we really wanted to do what was in the best interest of the patient. How do we create, greater access, lower cost, healthier patients? How do we keep our clinicians happy? Definitely mapping everything to that. So there was a real understanding of why we're doing this. How does this fit within the broader picture? And then it was an ongoing selling process. I mean, to be honest, you have to be out there. You have to be on the ground promoting these solutions with your clinicians as well as with the patients all the time, because it's new and it's foreign and it can be scary. And I think once you get enough of the spread around, then it naturally grows because you have grassroots efforts going at that point.
Yeah. Absolutely. Yeah. I totally agree. And, that clinical workflow integration is really what we've seen as critical to enabling that. And, I think one of the biggest challenges that I've seen to scaling programs is when they are started with these sort of monolithic applications that kind of live outside of clinical workflow or are a standalone app, standalone mobile app or a standalone web application, and there was no forethought into how the back end is going to actually integrate into the clinical data systems. And it's fine when you're running an initial pilot program to have clinical documentation live in a web portal, but to your point, Angie, when you're getting hundreds or thousands of clinicians engaged, you can't ask them to log into a separate interface, right? Their clinical documentation is in the workflow. Like you need to have the remote monitoring data or whatever the data are for the program actually in the workflow so the clinical documentation can live there. And I think that's a really important key piece that we've seen for programs that have been successful to scale is they start with that really smart workflow integration up front too.
And I would add,
Go ahead.
No, I'd only would add is buy-in not only on the operational and clinical side, but buy-in from the patient too, right? I mean, we have to be able to say, hey, because of this is how it's going to add value to you. And so same thing on the clinical side, hey, by doing this program and collecting this data, this is how we're delivering value to you as well, right? So, and you need both sides to adopt this program for it to work. And so, you over-index on just the member experience or over-index on the clinical value, that's where you're not going to scale because you're going to see decreased utilization on the other side of the equation. So I think both sides are really important.
Yeah, I think that's such a great point. And, I often tell my team, and I've said it before on these webinars too, but, we often talk about the consumer experience, right? And that's critical, engaging people in their own health, et cetera. But I don't think enough dialogue has really been given to treating the clinicians as consumers as well, right? And if you look at a lot of the clinical tools that are available for these programs on the back ends, it's very clunky, right? And you really have to provide something for clinicians at all levels that is going to be something that's easy for them to use. I think, Sara, to your point, it can't be just management by dashboard. It has to be management by exception and allowing them to really practice top of license. Like these are the benefits of these programs that can be realized, but it's only with thoughtful sort of engagement up front for the clinician as a consumer, in addition to the patient or member as a consumer. So, well, I'd love to move to wrapping up, and this has been just a fantastic dialogue. But in the last few minutes, I'd love to maybe have each of you just take 1 minute and say, if you could have a wish, that you sort of bring back to your organization heading into the new year around, how either clinical team members or executives or other staff members could be really thinking about expanding the opportunities around virtual care in 2022. Like, what would be the wish for you to sort of think about how they should be thinking about things moving forward?
I'll go ahead and start. So I think my number one wish kind of goes back to something you mentioned, Drew, is that I wish people would stop questioning whether or not RPM was going to last. I get that question a lot. Do you think we're really going to be doing monitoring? Yes, we're going to be doing monitoring. Yes, it's going to get cheaper, better, and more ubiquitous. So I think you need to get on board now and plan for it to evolve over time. So I find it just fascinating that people still think it might be a passing wave. It is not. It is how we're going to manage care moving forward. So,
yeah,
it's my wish.
Yeah, I think my wish would be that too much we think of remote monitoring, virtual care, or in person, right? We think of it's just these two things that can't coexist. And so how do we think about RM and virtual care as complementary and integrated services in the way we deliver care? I mean, it's just part of our portfolio. It's integrated. The data is all integrated. We're going to actually leverage that data in a way rather than keeping it in its own little program set to the side. And so I think if all of us as healthcare leaders sort of think about this is a lever that's part of our portfolio instead of just onto the side, I think that'll make a big difference.
That's great.
I love
Sorry.
what both Nelson and Angie said, and I agree with it, and I'll build on it by saying I wish that we could adopt some sort of big aspirational metric as an organization to say we are going to double access without adding brick and mortar and without hiring more people. Right. And then that gets you really thinking creatively about like, well, how do you do that? And what are the enabler? Like, you can only really do that through technology enablement if you don't want to burn everybody out, and they're already burnt out, by the way. So, so I think that's the adopting something like that that really just helps us think differently. That would be my wish.
Yeah, I love that. Thanks, Sara. That is, I think that's a really fantastic wish. And yeah, and I just want to thank all of you for being on this webinar. I think it's been a fantastic discussion, and my wish is for all of you to have a healthy, happy, and safe holiday season. And I look forward to talking again soon. Thank you all for attending. And again, as a reminder, we have our final webinar in the series, Trends in Remote Monitoring and Digital Health, on January 13th at 2 p.m. Eastern. So looking forward to seeing all of you there. And thank you so much. Have a good rest of your day.
Thank you.
Thank you.
Thank you.